Good afternoon, distinguished guests. Please welcome our Chancellor, Pradeep K. Khosla.
Good afternoon, everybody. Thank you for joining us for today's webinar. I just want to take a few moments before we start the actual conversation with our distinguished guests to tell you a little bit about what UC San Diego is doing to address this public health crisis on our campus. So on our campus, we've done several things. We have canceled in-person gatherings and moved all classes to remote instruction only. I can share with you that students and instructors have kept up with their academic progress, and there have been very few, if any, transients associated with that. Our staff have been really amazing. They also have kept up with the many operational changes, and most amazing of all are the healthcare workers who've been caring for the COVID-19 patients and preparing our hospitals for an influx of new patients. But literally as of this morning, the latest update is we had 19 patients yesterday, but today we only have 16. So we are hoping that this influx that we are preparing for doesn't actually happen, and that would be the best possible news we could have for the San Diego region. Our undergrads, most of them have gone home and they're taking instruction from home, and 82% in fact have canceled their contracts. So we only have about 18% undergrads and nearly 94% graduate students left on campus. We have enough space on campus that all the undergrads now are assigned to a single room, which means we are actually practicing extreme social distancing and making sure that there's not much close contact out there. On the health side, we are trying to increase our testing capacity. We are increasing the capacity of ventilators. We are keeping our hospital prepared for this surge that is being predicted towards maybe like 26th, 27th of April. But like I said earlier, we are all hoping that this never happens. We are also helping our community. In addition to us, San Diego is preparing for a surge, and they need beds, they need treatment centers. So we have offered them one of the brand new buildings that's going to be opened, or that was opened last week. We offered them 350 beds in that whole brand new building that they have accepted. So they're going to equip it and use it as a step-down facility or a facility to deal with mildly symptomatic patients. Clearly, I think this is exactly what a place like UC San Diego, a great public institution, should be doing. Our hospitals have postponed their elective surgeries, and this is coming at an extremely big cost or a price for our hospital. But nonetheless, this is something that I think we as an institution have to do to support the local region and to support the state. Hattie Mason and her team have been doing an amazing job. So if you see her, please thank her, because I think without her leadership, this would not be where it is today. Many of you have asked for how you can help. You can help by just being with us and letting people know that we are doing the best possible things we can. You can help us by supporting our work to the extent and ways that make sense to you. I can tell you, though, that we are meeting the challenge, and I cannot thank you all enough, our foundation board, our alumni, our local community members. Without you, we would not have been the great institution we are today, and we would not continue to be able to do the work we are doing today without your strong support. So please stay connected. Like I always tell people, I want you to own us physically, intellectually, and emotionally. So here we are, willing to be owned by you, and thank you very much for everything you do for us. On to our panel now, please.
Good afternoon, everyone. I feel really fortunate to be able to join you today to provide some perspective on the public health crisis that's being caused by SARS-CoV-2 virus and COVID-19 disease. I'm sitting here at home, as many of you probably are, practicing physical distances, which is a public health measure in response to the pandemic that we're all experiencing right now. But first, I just want to say that emergent infections, they're a recurring phenomenon. SARS-CoV-2 virus is just the latest example. Most of these emerging infections are zoonotic, and my colleague, Dr. Schooley, will probably talk a little bit more about how they get passed from animals to humans, or amongst humans, but this has rightfully commanded our attention right now. This COVID-19 pandemic has caused really unprecedented action around the world, and I just want to talk to you a little bit about what's happening at UC San Diego in terms of our public health programs and how we're interfacing with the medical school, the hospital, and others on the campus. So just a bit of Triton public health history. Some of you in the alumni community may know that since 1966 at UC San Diego, we've been engaged in public health teaching, in clinical activities, as well as research activities. And much of this has happened in the medical school with some important and some really complementary activities happening in units on other parts of the campus. In 2013, we launched a Bachelor of Science in Public Health program. It was an incredibly popular major. It attracts almost 400 students a year. And then 6 months ago, the University of California Regents actually approved the Wertheim School of Public Health. And so we joined UC Los Angeles and UC Berkeley in having a School of Public Health. And this was largely because of a commitment to strong public health training, a vision for public health at UC San Diego by Dr. and Mrs. Wertheim and the Wertheim Family Foundation. And so with that, we've really been able to begin to look at where public health is happening on the campus and pull our resources together. So in this great time of need amongst our UC San Diego community, we have the human resources, we have the intellectual capacity to really contribute in valuable ways. Initially, we started with trying to think about how to contain this pandemic spread of COVID-19, and now we're thinking about mitigation and control. And so I teach in the undergraduate program in public health, and one of the things that I tell the students on the very first day of class is that when things are going well, no one notices public health, right? And so it tends to attract people who are humble, with a great amount of compassion and care for others, who don't necessarily need to be in the limelight. But when great epidemics or pandemics periodically strike, public health comes right to the front and center. Some of you may remember the AIDS epidemic of the 80s, or the polio epidemic of the 50s, or maybe you've heard of, even though you didn't directly experience, the pandemic flu of 1918. This history is important because it instructs us on the rapid response that we need by really the entire international public health community to try and forge a response to pandemics and epidemics. Often you'll hear a lot about the U.S. Centers for Disease Control and Prevention. In these efforts, they helped us through Ebola, through SARS, which is the severe acute respiratory syndrome, or the H1N1 flu epidemic in recent times. This is dangerous to humans because emerging viruses, we have to think about three properties of them: how infectious they are, what do we need to cause infections in humans, how transmittable they are, how readily they go from one individual to another, and the severity of it. You know, on the spectrum of illness, from asymptomatic to lethal or deadly disease, what can we anticipate? And with this new SARS-CoV-2, essentially a 3-month-old virus, we see that there's pretty high transmission amongst humans via a respiratory route. And again, my colleague, Dr. Scully, will talk a little bit more about that later. But what I will emphasize is that the response that we see happening right now largely kicked off here at our county Department of Public Health, and then very well supported by Governor Newsom in the orders that you hear in the state of California around really managing travel and thinking about what's happening with our schools and our other places where we gather in our town, in our region, and creating physical distance will allow us to spread the infection to the point where our hospital system is not forced to deal with larger numbers of sick patients than they can properly treat. And I will emphasize that the interface between the public health and medicine is so incredibly critical at a time like this, because it is not possible to prepare for some of the potential scenarios that we see when nothing is done in the public health space. Our hospital systems are incredibly sensitive to epidemics and pandemics of this sort, and we will likely exceed the capacity of anything that you can do with the hospital system or with medicines. So we really need to think about the importance of strong public health. So a number of things play a role in how things play out across the globe. And you've probably seen so far that in different parts of our world, the amount of disease prevalence has to do with how urban those areas are. You can, in recent days, take a look at what's been happening in New York, where there's quite a bit of urbanization. There's a lot of public transportation and limited distance amongst individuals. The opportunities for travel, mass gatherings, and these things really do impact how areas experience COVID-19. Now, with regards to what we would need to think about here on the UC San Diego campus, throughout our San Diego community, and in California, as well as around the world, as we move forward and try to find our way to the other side of this, is a strong public health infrastructure and the resources to maintain it. We also need to think about building capacity, and I'll talk a little bit more about that shortly, and the scientific knowledge and social trust that we here at UC San Diego can help to create as we deal with this complex and challenging situation. So with regards to our public health infrastructure, we here at UC San Diego have a very strong commitment to doing this training. I speak on behalf of our Department of Family Medicine and Public Health, where I currently serve as the interim chair. And we have a very broad and deep suite of training activities that we engage in with our students who train at UC San Diego. We also need to think about the way that these things stress our systems beyond capacity. Our frontline healthcare providers across the globe can really benefit from public health efforts to bolster what they're doing in thinking about how our students can be activated, and we've been outlining in recent hours how to give them an unprecedented practicum experience that interfaces with public health learning and the healthcare system. Thanks to many of you for all you've been doing to support where we're going with public health. We look forward to continuing this journey with you and hope that you'll continue to support us. As you know, one of the core principles of public health is trust, social justice, and equity. And in times like these, communities that already experience quite a bit of health disparities are hardest hit. Those without health insurance or access to telemedicine, or they don't have big savings accounts, or unstable, insecure food situations and housing situations, they compound the challenges that one experiences with COVID-19. But I will say that it's my privilege to work for UC San Diego, where we have a world-class medical school, hospital, public health program. We're all collaborating daily, hourly really, to address this challenge. And you as the Triton community can also help us as we move forward in these efforts. So in many ways, to deal with this, it really has required that our system digs deep and helps us to bring out the best of who we are and recognize our common humanity. And I, again, feel so fortunate to have the opportunity to talk with you today about these efforts.
Well, I'm Robert Schooley, the Senior Director of International Initiatives and also a Professor of Medicine in the Division of Infectious Diseases in the School of Medicine. And I'm also delighted to be here with Dr. Anderson, Dr. Koshler today to have an opportunity to talk with some of our most important supporters and friends as we go through a very complicated time, not just at UC San Diego, but across the world. And I think as in all other areas of challenge, UC San Diego is doing all we can to come to table and do what we can do to help us meet our needs societally, both here at the institution and across the world. As Dr. Koshla says, our medical school and our hospital system have been preparing for this now for about 6 weeks, and the hospital has done a fantastic job, I think, of being ready for any surge that comes our way. The medical staff has pitched in and is ready for anything that comes to our door. So far, we have benefited, I believe, substantially by Governor Newsom's imposition of a stay-at-home order across the state of California at a much earlier time in the Southern California epidemic than in many other parts of the U.S. And our hospital census, as Dr. Koshla said, has remained relatively stable for about 2 weeks, and we are keeping our fingers crossed that this will continue. But it really has allowed us to be prepared for things that might come our way, and we're both keeping our fingers crossed and also we have our hearts out to the people in other parts of the country, healthcare workers and patients on the East Coast and increasingly in places like New Orleans, Atlanta, and other places, so that the public health interventions that are critical, as Dr. Anderson said, can continue to work their way through the system and at least bring the epidemic down to a more manageable situation than it is now in these hotspots. We're a biomedical campus that has incredible strengths in how we approach our challenges along these lines. And very quickly, UC San Diego has pivoted to approach the coronavirus outbreak on multiple fronts. We were among the first centers in the country to initiate the NIH's remdesivir study, which is a drug that is under development and under investigation for its activity against coronavirus. We know it has activity in the laboratory. We know it protects animals in animal challenge studies, and we're testing it in people, in our patients, so that we hope that over the next several weeks, we will find that it is benefiting people who are receiving it, and it can be made more available more broadly. We're also involved in multiple other clinical trials supported by both the National Institutes of Health and by industry to study tocilizumab to see if we can decrease inflammation, to reduce the more severe late-stage illnesses that some patients get into. Hydroxychloroquine is a drug you've heard a lot about in the public from President Trump on down. The problem with it is it hasn't been studied in rigorous clinical trials, and we're standing up rigorous clinical trials here that will collaborate with other centers across the country and get a definitive answer about whether the drug has an impact on the disease, and if so, which patients are the most likely to benefit from it. We're also involved in the NIH's studies of passive immunotherapy using immune globulin for people who've recovered to see if we can help them, help people who have not yet become infected, avert severe disease. And our drug discovery people who work in the laboratory, are busy at work looking for new compounds to follow the compounds that are in patients already, to bring them to the bedside to also see if we can benefit patients in a second wave of clinical trials that will come out of our laboratory. Obviously, the longer term control of this disease is going to require a vaccine that is effective. And our vaccine effort is also very heavily involved. We have multiple immunology groups on the campus that are detailing the immune response to this virus during natural infection. These individuals are collaborating with many of the biotech companies here in San Diego to help design vaccine approaches that we hope will mimic the immune response that patients who get this disease and recover, and we believe are protected from reinfection, generate, so that we can do that with vaccines and stop the epidemic from recurring in the fall or coming back over the longer term. We're also beginning to do vaccine studies ourselves. The Institutional Review Board is beginning to review vaccine proposals, and we hope to be vaccinating volunteers here at UC San Diego in the next week or two. We've also been very heavily involved in trying to protect our workers and other workers with some really very, I think, interesting and important work going on in our School of Engineering. The engineering school has been working on 3D printing to develop face masks that will protect healthcare workers, given the shortage that we have, and is also looking at the use of UV light and other approaches to sterilize the N95 masks that are in such short supply so they can be reused safely and extend their lives. And finally, a very innovative group that is working across lines of the School of Medicine and the School of Public Health, as well as the Jacobs School of Engineering, is working on developing fast ways to make new ventilators in case we need to push the ventilator supply beyond what we currently have. We're very fortunate right now because of planning done at the hospital that we have enough ventilators to support the patients we currently have and ones we think might occur during a surge. Being very careful with them. We don't have a large surplus, but we are comfortable that we can support the people from San Diego who come to us for care. So I'll stop at that point because I think it's really important to have an opportunity to try to address questions you have. We've seen some very insightful questions coming in the pre-event stream, and we're looking forward to spending some time conversing with you with the questions that you bring to us from here on out. Thanks very much.
Thank you, Dr. Schooley. We have had a number of questions to come in for you and Dr. Anderson, and we will begin in just a moment. Oh, Dr. Schooley, if you will check your audio, I see that there's a malfunctioning. People can't hear the vaccine discussion. So actually, can I ask you to go back and do a little repeat about the vaccine discussion?
Sure. To control the epidemic over the longer term, it's going to be essential to have safe and effective vaccines. We are very heavily engaged in the vaccine development effort. We have a basic immunology community that is characterizing in great detail the immune response of people with natural infection to this virus that helps them recover. Because we believe that natural infection and recovery is the type of immune response that people need to generate with a vaccine to protect them from illness. We also are collaborating with vaccine companies here on the Mesa and further afield in California and elsewhere to help them study their vaccines in healthy volunteers here at UC San Diego and the Antiviral Research Center, which we hope will have us much better prepared by next summer if we're successful with the vaccine effort as a nation and as a world, as this virus will very likely continue to circulate unless we have a vaccine to bring it under control.
Great, thank you. For our first question, can you help clear up the facts around the symptoms and what warrants a call or visit to the ER, virus damage and death rate, and how to stay safe?
Why don't we let Dr. Anderson start with staying safe, and then I'll go to talk about Plan B.
Thank you. I appreciate that. And you read my mind. I was thinking that's a great place to start. So with regards to staying safe, thinking about basic hygiene and public health practices is a good place to begin. Washing your hands, ensuring that that happens thoroughly and effectively. 20 seconds is often recommended. Think about maybe singing the happy birthday song while you do it, or repeating the ABCDs, and really get the dirt you can see and you can't see off of your hands. And then with clean hands, you still want to minimize the amount of times that you touch, or at all touching your nose, your mouth, and your eyes. So keeping your hands off of your face can go a long way there as well. With regards to some of the public health practices, however, right now we've been asked to shelter in place, and this is not to cause us, inconvenience. It is really to try and prevent the spread amongst our general community. And so being distanced physically from others by 6 feet is going to be very helpful in terms of keeping you safe. Staying sheltered, because that again will minimize the amount of contact that you're going to have when you go out into general environments and having to think about distancing yourself. So those are some basic principles around how to stay safe at this time.
In terms of the symptoms that may occur in people who do get infected, it's important to realize that as the virus has been circulating for a while and we've learned more about it, we've learned there is a wide spectrum of disease. As in most infectious diseases, the first cases we learn about are the most severe ones because they're the ones that get the attention of people in hospitals. We know now that this virus can cause infections in people who have no symptoms whatsoever. And that's why it's very important for the message that Dr. Anderson just gave you about continuing the social distancing and hygiene are important, because people can shed the virus who don't have symptoms and are unaware of their infection. Now, after you get infected, the length of time between being exposed to someone with a virus and developing symptoms varies from as short a period of time as 2 days to as long as 14 days. But most people who are going to develop symptoms will do it within the first week. It's important to know that while you're having symptoms, you will shed the virus. It's also true that we can find viral RNA in stool, although we don't know how important that is in spread. We think we focus mainly on virus being spread by droplets from our mouths and noses, and also by things we touch with our hands after we get those droplets on our hands. That shedding can occur as early as 72 hours before people develop symptoms. So it's another reason to be careful and to continue to follow the public distancing recommendations that are currently working our way through the country. Now, once symptoms develop, there is a wide range of how people do. In general, people who are younger and who have no underlying diseases do much better than people who are older and have underlying illnesses. That's true for many illnesses that we have, but it's particularly true for this one. Children who get infected will often have very few, if any, symptoms. We're learning that. But as you get older, the likelihood of having more severe disease increases, starting about the age of 55 and continuing to rise all the way into the 70s, 80s, and 90s. And this is why it's particularly important for people in these age groups, and to add to that, people in these age groups in particular who have underlying lung disease, asthma, diabetes, obesity, hypertension, not put themselves in the public where they become infected, because these are the people who are at the greatest risk for developing severe respiratory symptoms that can lead to death. Now, I should emphasize that this occurs in a very small minority of patients overall, but it occurs in a larger and larger fraction of people as you get older and as you develop these comorbid conditions. The usual course is that most people will have a fever at the time they present. About 80% will. Only about half of people will have a cough. You may have a runny nose, but it's actually unusual to have a head cold, and those kinds of symptoms we're used to with flu. It's important to know, though, that flu is also circulating, and people can have both viruses at the same time. So although SARS-CoV-2, as we call the virus that causes the disease, doesn't cause a runny nose and a head cold, it doesn't mean that you can't also have influenza at the same time, and you shouldn't use that as reassurance that you don't have SARS-CoV-2 infection. Over the course of 3 or 4 days to as long as 10 days, most people will get over their acute illness, which usually consists of fever, malaise, tiredness, a sense of being exhausted that persists over this period of time. The recovery is gradual, and most people, the disease is over in a couple of weeks with what we think are very few sequelae. In a minority of people, as they start getting better, they will then go into a second phase of more and more severe disease, in which you develop a progressively severe inability to oxygenate your bloodstream as your lungs get more and more inflamed and more involved by an inflammatory response, which we think is driven more by an immune system that doesn't know how to turn itself off, as opposed to ongoing viral replication. These folks end up needing to be in the hospital with intensive care support, and many of them do recover with good intensive care support. It just takes a time, up to a couple of weeks in the intensive care unit. So this is a serious, but not always irreversible condition that occurs, as I've already mentioned, in people with these underlying conditions. These people, we think, can go on to have ongoing lung damage that may be a problem later on. We don't know this, how often that occurs and how severe it is, because we're only beginning to see people recover and go back into the community. And these are the kinds of things that need 6 months to a year of follow-up to see how people do in terms of the long-term recovery. But those are the general remarks that I have about the course of infection that happens most of the time. One thing I should say is one unusual finding is that up to about a third of people will lose their sense of smell and taste as they're developing their first symptoms. So that's an interesting finding. We don't understand the reason for it, but it's something to pay attention to.
Great, thank you. Our second question is, how can we help our communities? Are there opportunities to assist with research and/or PPE supplies and donations?
Let me let Cheryl answer the public health aspect of that, because as we begin to go into mitigation and other aspects of this, having the public involved in helping us find cases and deal with isolation would be very important. Do you want to address that, Cheryl?
Yeah, absolutely. So, we're in a phase now where we really need to think about, for every individual who's identified as COVID-19 positive, having, for the purposes of this call, we'll call it a case, it would be very helpful for us to know who those individuals have been in contact with. And so we really find that there is a gap and a limitation in our ability to do extensive contact tracing with individuals. And by that, we mean understanding not only how the person who has the diagnosis is experiencing the disease, but also getting symptomology and follow-up in the individuals who've been in contact with that initial person. Some of the things that we're using to influence how we approach this here in the San Diego area are some of the country experiences that have gone ahead of us. And so we are pretty familiar with what has been reported out of Wuhan, China, and how they got through the epidemic. We're learning a great deal from different regions of Italy. The area of Italy, the Veneto region, where they have extremely strong public health measures, has fared the best in terms of the country. And so really thinking about how we as a public concentrate on some of those public health activities and allow us to hopefully see the similar amounts of successes here. We also want to ensure that people stay in tune with adequate and accurate information at a time like this. And so ensuring that as you become more educated around the issues, you pass on things that have been vetted and that are going to be useful and truthful. So with regards to how you can help, one is be mindful of and check in on what the public health cautions are in the areas where you live. So, for us here in California, we are doing our best to physically distance. I noticed one of the questions is, what are these projections? What are they based on? Why and how can you say that, we anticipate a surge in a number of people who are experiencing this? How can you say that, we shouldn't be congregating, we shouldn't be having church services or school services, et cetera? And so a lot of that is based on our ability to do predictive modeling. And the results of those models suggest that the public can help by adhering to the public health measures. We have 3 of them in place, and these models assume that all 3 have relatively strong adherence from the public. So that is that we don't travel around, right? There's a travel ban in place and we adhere to it. That we don't congregate. Right now we have an order that no more than 10 of us should be gathered, but really with the shelter in place, that minimizes that number down quite significantly. And if we're able to do that as a public, a community really working together, supporting each other, we can help to bring down the number of and the impacts of this situation on our hospital systems, as well as on our general infrastructure and economy. So I'll give you just 2 scenarios here. When we look at I'll start with sort of the most pessimistic scenario, models known as the Ped Model or the Imperial College Model. You see that in San Diego we would need 10 times the capacity that we currently have to manage a potential surge in cases as we experience this pandemic. We more recently have statistical models. Those models are mechanistic. We have more statistical models that tell us that based on the experience in Seattle, King County, as well as some other parts of the world where we can really see those epidemic curves and statistically model them, that if we adhere to public health measures as a community, we could experience what is reasonable and manageable for our healthcare system. So I'll pause there and let Dr. Schooley chime in.
The public can help in research in a couple of ways. We're going to need healthy volunteers to volunteer in the vaccine studies. These are going to be time consuming. They're going to be complicated. One of the issues that we know from animal studies is that for some reason, the key elements of the immune response required to protect from these coronaviruses are much easier to elicit in young animals. It is it's very unlike other, it's out of proportion we see with other viruses. So we will need people of all ages to participate in vaccine studies. In some ways it's even more important for older people to participate here because those are the ones who are at greatest risk of disease if they happen to get infected. During the treatment phase of this, we'll need the people who are end up becoming infected despite the efforts that we're trying to introduce at the public health level to participate in the clinical trials that will lead us to understand which drugs work the best and which patients are best to use them in. And we always need general broad support of the community and the public to emphasize that we are at our best when we use knowledge and science to make rational decisions about complicated problems like this. One of the things that has made it our response to this be so sporadic and slow in many ways has been this on the part of our political leaders over the last decade and a half. This is very dangerous, and those of you who are alumni and friends of UC San Diego, a very science-driven institution, can help by pushing back when you hear people telling you things that are not based in science, and presenting to them the material that actually we spend a lot of time trying to generate. That's how we should make decisions. When we don't do that, we make mistakes.
So can you all tell us what insights or questions this pandemic is raising about telemedicine, public health, and the safety of healthcare providers?
One of the things that I mentioned earlier was, a real core principle in public health is thinking about how do we ensure equity in how we deliver medical care or public health recommendations and practices. And I'll just raise this for your consideration because we have mounted a really strong and important response with telemedicine to how the practice of medical care is happening right now. It allows patients to stay connected with providers, allows important health conditions and treatments to continue to occur while we are needing to manage this situation. However, the digital divide is still real for many individuals. And so in thinking about, the work that many of you do or the resources that you have, helping to bridge the opportunities for people to be able to participate in those telemedicine visits because they'll have the kind of devices that allow them to connect with their providers, et cetera. We are cataloging in the primary care setting, particularly in Division of Family Medicine, how we're seeing this play out. What are the characteristics of individuals who aren't able to participate in telemedicine visits, whether that be by age, by race, ethnicity, or other personal factors or environmental factors. So that's one angle that I offer to you to consider as we think about this. Dr. Schooley.
So the other thing we're learning about protection of healthcare workers is that many of the things that we do or don't do and hiding, we get spotted when we don't see a threat. In the New York hospitals, in fact, it was found that the people who are at greatest risk in terms of getting infected in the hospital in the first wave weren't the ones working in the intensive care unit. They're the ones working in the non-intense parts of the hospital, regular medical and surgical wards where they were not as attentive to washing their hands as they might, and where people weren't wearing masks. They weren't at that time allowed to wear masks. And I think the message here is we know how to protect people when we know who's infected, but we don't always know who's infected. So in terms of the healthcare setting, we need to, I think a little more broadly about how we approach things. We need to protect all of our healthcare workers, both of them. They're out there doing their jobs that are essential. We also need them not to become vectors of the disease and spread it to other people. So that we need to make sure that in the hospital setting, we're assiduous about identifying people who are infected and getting them aside until they're ready to come back to work. The only way to do that is to pay attention to infection control throughout the hospital. Now, interestingly, people who recover from infection can be very important in helping us as we go forward, because these are people who are going to be immune, we believe, from reinfection, at least over the course of the next year or two, and could be people who can work without as much anxiety as many people have and should have, being around the virus with a potential for infectivity that we've been talking about.
This is a longer question, so bear with me here. But given the importance of data and modeling analytics to understand how the virus spreads and impacts different demographics, how do you view the data China has reported? Is it believable, and how much should the U.S. rely upon it when modeling potential outcomes and strategies to mitigate the public health and economic impacts?
Yeah, maybe I'll start here, Dr. Schooley, if that's okay with you. I think when you think about the ability to predict based on mechanisms or statistics or other things, you really have to consider the sociocultural environment around you and the context that those models are going to apply to. And so whether we're thinking about the experiences reported from China or the experiences reported from Europe or other parts of our country, I think the key question to step back and ask as we approach, what information we put into the models is, is that relevant to our local context? And so I think for several reasons, we want to really emphasize looking to areas that look more like us in terms of how we typically discipline ourselves around health practices, how we typically exert our public health practices in terms of our state, local, and national government orders and things of that sort. So I will, let Dr. Schooley comment further, but I'll say that we've been learning quite a bit out of Europe, particularly Italy. And even though right here in our country, we have different places experiencing it, we know that, we're not the same as New York, and we're not even the same as Seattle, King County, even though we can find similarities more so in one location than another.
I think the other thing that's important to know is that although we are different from China in many ways, I think and although the data may not, from China's approach may not be directly applicable to us, because they really did things that would be hard for us to do in the US in terms of having people stay at home and soldiers patrolling the street and neighborhood shaming groups to keep people home. They were in a New York-like situation. So in some places, those kinds of approaches may be required. But what we do know is that in the US already, the impact of these social distance has been highly dependent on when they were introduced. Places that waited, like Florida, will be a disaster. Places that did them earlier, like Southern California, we're hoping will be better off over the middle and longer term. Two very good comparisons are what happened in Kentucky and in Tennessee. They had basically the same situation with one case in both states on March 6th. The governor of Kentucky declared an emergency and began to do things like close schools and tell people to stay home. The governor of Tennessee said, I don't need to do that. There's no problem here. And was about 10 days behind the governor of Kentucky in doing anything. And by March 20th, there were 48 cases reported in Kentucky, despite a lot more testing compared to 240 cases in Tennessee. And the difference here, I think, is mainly because of the delay in imposition of the distancing effort in Tennessee compared to Kentucky. Ohio did the same thing. They got on board early on, and most of the cities in Ohio are doing better than some of the other cities we're seeing perk along. So I think that although the approaches may be different from city to city depending on our social structure, we do have good evidence they work, and we have evidence they work best if they're done at a time when the amount of virus circulating in the community is lower. If we wait until the hospitals are full and say, oh my God, this is terrible, we've got to do something, that's too late. Unfortunately, that's the easiest thing for politicians to do because they want to have something dramatic they have to respond to, rather than doing what Gavin Newsom did in California and saying, we're beginning to see a problem, we're shutting down. And I hope that more of them will learn that lesson and that we can benefit from what I think is increasingly showing in these uncontrolled experiments can be quite effective.
Yeah, and I saw that there was a question that came through around, you're living in a part of the country where you haven't yet been asked to shelter in place, or, the public health orders haven't come forward from your governor or from your local public health department. And so I just want to reemphasize the point that Dr. Schooley is making here. We are collaboratively thinking about this pandemic from a public health and a medical perspective. And, public health, we build that fence so that you don't fall off the cliff and need the ambulance to come and get you after the fall. And so, really getting the energy around the public health practices that we see working in the places that are experiencing the epidemic before us is quite important. So if you're in that part of the world or country, do begin to do some of these practices, even if you're not seeing great surges just yet.
No, you don't need the leaders to tell you what to do if they're not giving you good advice. I think a lot of the things that this is telling us is that often the people in the communities are more aware of what's going on and more willing to take action than their governmental leaders are. And suppressing information doesn't work. In Wuhan, there was an effort early on not to be transparent about things. And before they introduced their cordon sanitaire, their isolation of the city, 5 million people left. The people knew what was going on and they were out of there. In New York, people began to realize there were problems before Cuomo did, and many people left Manhattan to other places because one of the first surges of cases in New York was Allen Stony Brook because people had bailed from New York City. So I think you don't need to wait until people tell you what to do in terms of sheltering in place and minimizing your public contacts, because the people who make these decisions often have other pressures on them that are not scientifically driven, and we should be a scientifically driven society.
So there are a lot of good questions here, and it's hard to navigate which one to ask, but we'll try to get one or two more in here. Can you both talk about our involvement and partnership with the CDC, WHO, FDA, and other institutions that help drive the development of research and vaccines on a regional, national, and global level?
Yeah, well, I'll just quickly add that from the public health perspective, we here at UC San Diego are fortunate in that we have several of our faculty who are either surveillance officers in past career experiences from the CDC. They have a great amount of experience in screening and used and developed some of that expertise at the CDC. And we have really taken stock of what our faculty resources are, what we've been training our students and what they're now able to do, and using some of that to figure out how to support the local response.
In terms of vaccine development effort, I think the FDA is going to be very much a partner in this. They've been very supportive of developing novel therapies for multi-drug resistant bacterial infections and major public health threats. And I think I don't see any issues with the FDA in giving approval for the use of drugs in clinical trials or vaccines in clinical trials. They were faulted, I think, in many ways rightly, by being slow to authorize the use of academic laboratories to roll out PCR testing to be able to get a better understanding of the extent of the epidemic when the CDC's effort failed. And we need to make sure they don't do the same thing with serologic testing. Yesterday there was evidence that Ambassador Birx suggested that academic labs do this if the FDA regulated process and clinical laboratories are too slow in getting it out, because it's very important to know the course of the epidemic. And so I think I hope the lesson was learned, because the FDA has been quite permissive in this area. The lesson was learned from the NAT testing that sometimes the perfect is the enemy of the good, and we can end up getting behind the curve when we are not able to move quickly. So that would be my long-winded answer to your question. But I see the FDA in particular as an institution that has a lot of depth and can really help us in this vaccine and drug development area. And finally, I should say the real driver of all of this is the National Institutes of Health. That's where the research funds come from to develop vaccines and drugs, and the FDA regulates them. The CDC may tell us how many people need them, but the science is driven by the NIH and the NSF, and any support you all can give to them is, I think, going to be very important in this and other biomedical crises.
Thank you, Drs. Anderson and Dr. Schooley. We appreciate your time today. We know you're very busy and helping many patients and community members. I hope that we can call on you to answer some of the questions that we didn't get to, that we can send out to our audience and answer all of the questions that we have available, if the audience would be patient and give us some time to get those questions answered for you. We'd like to thank you for your time today. This is just one of many webinars that we plan to have over the course of the next few months, since we cannot gather together in person. We are here for you as a university. We want to support our community, our alumni, our students, our friends, our faculty, our staff. So if you have suggestions for other webinars, please feel free to contact us at alumni@ucsd.edu and stay in contact with us. We also ask you to stay engaged or connected with us. If you have the ability, thank you to so many of you who are already supporting us through contributions, sending supplies, sending messages to our healthcare workers. But if you have the ability and would like to support the COVID-19 efforts, please see the link on your screen and feel free to support us as we continue to battle this epidemic. Thank you for calling in today. Thank you for being a part of UC San Diego. We appreciate your time and look forward to seeing you in the future. Have a good day.